hemi, and if it's complete with don't you move with associated with the spinous process with the aim of decompressing the cervical spinal canal. Now, it's a common neurosurgical procedure that is done by spine surgeons to either to decompress the spine in cases of spinal stenosis or for other indications, as we'll see as we proceed. Now, it is usually recommended when there's significant cervical canal stenosis. Usually, the canal diameter in adults is an average of 12 millimeters, but if it's less than 13 millimeters, it is taken as significant stenosis. Commonly done indicated in patients over 50 years in cervical degenerative disc disease, which is commonly acquired, and usually patients with this cervical degenerative spondylosis, stenosis present with neck pain, radiculopathy, and myelopathy. Now, a clear understanding of the anatomy of the cervical spine is vis-a-vis a proper indication, and proper patient selection is key for a good outcome. The cervical spine consists of 7 cervical vertebrae numbered 1 to 7. The first 2 are atypical vertebrae. The first is the atlas vertebrae, and the second is the axis. Now, the atlas has the characteristic of not it, however, has two huge lateral mass and inferior articular facet where it articulates occiput. The axis, on the other hand, has a well-developed body with an upward projection, which articulates with the anterior aspect, the posterior aspect of the anterior arc of the atlas. Now, this diagram shows the relationship between the atlas and the axis, with the odontoid process articulating with the atlas there at the atlanto these joints there between the odontoid, the axis and the atlas. Now, it is held down by several ligaments, as you could see there, the transverse ligament, the anterior and posterior articular surfaces. Then, of course, it has a tubercle there. Sorry, I can't see any slide now.
Presenter, can you hear me?
I can hear you, sir, but I can't see any screen, sir.
Maybe you have network problem. Can you reshare?
Oh, it's actually Dr. Opalike that is sharing for us. He's trying to reshare.
Okay, so there must have been a network glitches.
I think it's coming on, sir.
Sorry about the interruption.
You're welcome back. Sorry, listeners.
This slide shows this skeleton of the cervical spine. with the subaxial complex shown there, the lateral aspects, and of course the posterior aspect. Now the second, the axis and the entire subaxial complex have spinous processes. The spinous processes of C2 to C6 are bifid. C2 is particularly noted to have a very prominent bifid spinous process. The spinous process of C7 is very prominent, but it's not bifid. Okay, this slide shows the lateral aspect of the skeleton of the cervical spine. Now, on the cervical vertebrae are oriented such that the lateral masses, they have a transverse process. This transverse process has a transverse foramen, the foramen transversarum. From the first to the seventh have transverse transversarial. However, the vertebral artery, when after it arises from the first part of the subclavian, enters through the foramen transversarum of the sixth cervical vertebrae and traverses the entire superior cervical vertebrae, but it doesn't pass through that of the seventh cervical vertebrae in most cases. The literature has that in only about 5% of cases where it passes through that. Now, this shows a typical cervical vertebrae showing the lamina. The lamina and the spinous process constitute the posterior elements of the cervical vertebrae. Now, the lamina begins just at the base of the spinous processes and ends just before the lateral mass. And it has a superior border and an inferior border and an anterior surface which is in contact with the medullary canal, and a posterior surface which provides attachment for the posterior nuchal muscles. Now, it's important to note that anterior to lining the anterior wall of the lamina are the ligamentum flavum, which is in contact with the theca of the cord. Now, it connects both lamina, and lines extend from the lamina of C1 down to as far as S1. Now, this just shows features of typical cervical vertebrae as I've already. Next slide, sir. Now, talking about the previous slide, sir. Previous slide, sir.
Thank you.
The slide on the ligaments. Yes, sir. So thank you, sir. Now, the slide on the right shows this lateral aspect, the mid-lateral aspect of mid-sagittal aspect of the cervical spine. Now, it shows posteriorly on the surface, arising from the external occipital protuberance and running down to the tip of the seventh cervical vertebrae, the nuchal ligament, and just deep to that is the supraspinous ligament, which connects the tips of the entire cervical spinous process of the cervical spines. Then between the spinous processes are the interspinous ligaments. On the left is just an MRI showing the relationship between the cord, the spinous processes, the ligamentum, and the vertebral bodies anteriorly. Next slide, sir. Now, this diagram shows, the one on the right shows the vertebral artery arising is painted depicted in green here, arising from the subclavian artery and entering first through the foramen transversum of the sixth cervical vertebrae and continuing up till that of the atlas, and then turning a bit posteriorly before it joins the other one, the contralateral one, to form the basilar artery. Now, it's important to note that just proximal to where the vertebral artery exits the foramen transversum of the atlas, it passes through the suboccipital triangle. Now, this slide shows the musculature of the posterior musculature of the neck. Now, these muscles are in 3 layers. The superficial layer is being shown here and consists basically of the trapezius. The other the middle layer is dead, showing the consists of mainly the longissimus capitis, semispinalis capitis, and cervicis rectus capitis, posterior major and minor muscles, and the obliquus capitis inferior muscles. Now, in this dissection, please, the previous slide, sir. Now, in the midline, there you can see the median raphe, which is an avascular plane through which dissections are done. You saw peripheral dissections are done to ensure that bleeding is minimal. Next slide, sir. Okay, so now this slide shows the muscular attachment to the spinous process of the axis. Now, about 5 muscles are which are all attached to the spinous process of the axis and must be preserved to ensure that extension of the neck, head and neck, is preserved. Now, these muscles attached include the obliquus capitis inferior, rectus capitis posterior, semispinalis, cervicis, multifidus, and the interspinalis. Next slide, sir. Okay, this is just showing us the layers of the muscles, of the posterior nuchal muscles, superficial consisting mainly of the very widespread trapezius, the intermediate, the splenius capitis, and the deep, the other ones constituting the deep layer, semispinalis capitis, semispinalis, rectus capitis posterior, minor, rectus capitis posterior major, the obliquus capitis inferior, longissimus, and the splenius capitis. Okay, and the longissimus capitis, sir. Okay, the indications for cervical laminectomy that include patients with multi-level canal stenosis, usually with preserved lordosis and myelopathy. Now, it can equally be done for patients with radiculopathy, cervical spondylosis radiculopathy, particularly in those whom medical therapy has failed. Now, this medical therapy will include physical therapy, analgesia. It's equally done in patients with diffuse ossified posterior longitudinal ligament. And it's indicated in patients when anterior pathology of the cervical spine is superimposed on cervical canal stenosis, and when the latter is markedly diffuse and significant. Now, it's equally indicated as a means of exposure for cardotomy, arthrodesis, and cervical spine instrumentation for deformity correction. It's equally done to assess intraspinal pathology in like tumor, vascular malformation, abscesses, or even hematoma. Now, one other indication for cervical laminectomy is posterior cord compression resulting from buckling of a thickened ligamentum flavum, which of course is just deep to the lamina. As the lamina is taken out, the ligamentum is obvious there. Now, factors limiting, when there are factors limiting anterior neck dissection, like in patients with a short neck or scarring from previous irradiation or post-anterior neck dissection, posterior cervical laminectomy is preferred. It's equally preferred when there is the pathology. Now, when the areas of cervical stenosis is high up or low down in the cervical spine, like at C6, T1 level or at C2, C3 level, where anterior approach will be quite difficult. Now, in professional speakers or singers who will not want to take the risk of having any permanent change in voice because of the risks of injury to the recurrent laryngeal nerve, posterior approach is preferred in those ones. Then in the elderly too, with comorbidities who may not want tolerate significant blood loss, posterior approach is preferred. Next slide, sir. Contraindications to posterior cervical laminectomy include when there's straightening of normal cervical lordosis or kyphotic sagittal alignment. Now, this is because there's a high likelihood of instability following cervical laminectomy. When there's cervical instability resulting from trauma, tumor invasion, or connective tissue disease too, then when there's a broad-based ventral pathology that may be readily assessed from the anterior approach, sometimes the combined approach can be done and not just a posterior cervical laminectomy, sir. Thank you, sir.
Good evening, trainers and colleagues present. I'm Dr. Eki Udoko. I'll be taking the other aspects of the presentation. For cervical laminectomy, as we all know, is a posterior decompressive surgery that can be done, which involves converting the spinal canal from a tube into a trough. Its primary aim, or the primary aim for doing a cervical laminectomy, is to provide the decompression for the neural structures. Next slide, stuff. The two main types of cervical laminectomy that is known is the standard cervical laminectomy as well as an extended cervical laminectomy. When we say standard cervical laminectomy, it just means when the laminectomy involves one or two levels above or below the area where stenosis is. And C3 to C6 laminectomy is a standard cervical laminectomy. When this limited laminectomy is done, or this standard laminectomy is done, usually done when fusion is not required and stability is maintained. For the extended laminectomy, it just involves extending the laminectomy to involve C7 or C2. In patients that will require cervical laminectomy, in the preoperative planning, good patient selection is key. That is, patients that may have the following indications that were said: posterior tumor that is compressing on cervical spine, a patient with cervical spondylotic myelopathy, which will benefit from cervical laminectomy, patients with intraspinal tumor. When such patients are seen and indications for the laminectomy is gotten, then an imaging will help in localizing as well as establishing if there's any translocation or or translocation or instability. Such investigations will involve an MRI, a CT scan with a myelography, particularly in patients that have a pacemaker who will not benefit from an MRI because of the magnetic effect on the pacemaker. For X-rays, plain X-rays are done. It offers us an access or to evaluate the bones of the cervical spine. The views are always done at the AP, the oblique view, or the flexion extension studies. The flexion extension studies will show if there is any translocation or subluxation. Plain X-ray will also show if there's any osteophytes, reduction in disc space, as well as if there's loss of lordosis or kyphosis. For patients that place or that now merit surgery, it is really important to assess patients' fitness for surgery, because these patients are usually elderly, or it can also be a young patient. A chest X-ray and echocardiography, as well as an ECG to assess patients' fitness for surgery is important. For patients that are on antiplatelet drugs, will need to be stopped. For patients that are on non-steroidal anti-inflammatory drugs, will also need to be stopped. Patient is cancelled on the benefits of surgery, the intended surgery that will be done, the techniques, and the risk that can be associated with the procedure, follow-up, as well as rehabilitation plans. Consent is taken, then patient is worked up for surgery. Equipments that are usually required are basic spine sets, which will have a round jaw, 1 to 2 mm kerosene punches, diamond drill bits. Headlamps, microscopes will help to make the surgery better. The Mayfield head holder is important, and intraoperative X-rays are required for localization. Other agents that will help in surgery are neurophysiological monitoring devices for nerve conduction studies. A capnograph, patient should have a central line as well as an arterial line. There should be pneumatic intermediate compression devices as patient is going for surgery. The normal anesthesia that is offered is usually general anesthesia with or without muscle relaxation. We may not need muscle relaxation if intraoperative physiological monitoring is going to be considered. A patient is intubated using an Amor tube, and for patients that will be, before positioning of the patient, baseline recordings are taken for the neuro intraoperative physiological monitoring. Records are gotten, vital signs. The patient is ensured that the systolic blood pressure is higher than 100 millimeters of mercury. Before positioning of patient, the Mayfield head holder is placed, and the patient is turned gently onto the operating table. Position is usually prone, with the patient's head placed in the neutral position with minimal flexing, and the arms are tucked by the side. Pressure points are padded, and patient skin is cleaned, and the proposed size is infiltrated with isotone. Before incision is made, localization of the area of surgery is marked, then incision is being made. With the surgeon positioned at the left side of the patient, because the patient is prone, the assistant on the right of the patient, as well as the scrub nurse, the procedure is is then continued. The skin incision is centered at the midline using the scalpel blade 10 with the aid of periosteal elevator, as well as with the aid of a monopolar diatomy. The incision is advanced from the spinous process that is palpated down to the lamina. The sub-periosteal dissection is done. Care is taken not to dissect through the muscles, as this will increase bleeding. Any form or any hemorrhage that may occur is coagulated, and the incision exposure is maintained with the application of a self-retaining retractor. For the bone removal, it's two ways. Either a drill, a high-speed drill is used, or a high-speed drill is used to make an opening just at the junction between the lamina and the laminofacial junction. Once an opening is gotten, the small kerosene is advanced into the opening, and bone removal is done gently. It is advisable not to it's advisable for the surgeon to know that there should be no compression on the cervical spine. For prevention, you can use a cotinoid to separate the foot pad of the kerosene from the ligamentum flavum. Opening is done bilaterally on one side at the area of compression, as well as the other side. So as the dissection continues down until the ligamentum flavum is seen, it is advisable that the bone remover should be, the central aspect of the lamina should be removed first before the lateral aspect is removed. Why? Because when the lateral aspect of the canal is open first, there is risk of injury to the valvulus and veins, epidural veins, which can easily bleed, and control of the bleeding can be difficult. After removal, after completion of the laminectomy, any bony bleed is controlled using the bone wax. For patients that will require foraminotomy, the patients can be gently rolled or tilted to the opposite side to offer better opening. The foraminotomy should be done as far as lateral to the facet joint. For patients that may need removal of the facet joint because of hypertrophy, it is advised that not more than one facet joint, a total of one facet joint should be removed. For the facetectomy, you can remove as far as 40% of the facet, which will not offer or cause any instability for the patients. For other considerations that is advised is in patients that you may want to extending the laminectomy to involve C2 or C1, it's recommended that patients should have a straightened cervical spine. For patients with hyperlordosis, because of the risk of tension on the nerve roots as well as the blood vessels, we can worsen the patient's neurological state. It's advised that limited laminectomy should be done, and that should suffice. To avoid significant destabilization of the cervical spine, it is advised that the soft tissue over the facet joint should not be removed, as if it is done, it may cause dysvascularization of the facet joint and subsequently worsen the stability of the spine. Meaning dissection in laminectomy should be as far as the extent of the spinal canal, should not go beyond there. Next slide, sir. Following laminectomy, the wound is irrigated, hemostasis is secured, then the subfascial closure is ensured with a drain in place. The drain can be removed after 24 hours, or if the drainage within 12 hours is less than 50 mils, the drain can then be removed. Post-operatively, after surgery, antibiotics are given. Analgesic is key, as the patient will have post-operative pain. For patients that have numbness or paresthesias, they will do well with neuroleptic drugs like pregabalin. Following surgery, it's important that the patient should have the cervical collar applied, because the surgery, particularly in patients with cervical spondylotic myelopathy, said that the surgery that is done only takes care of the static stenosis. Dynamic stenosis, surgery does not treat dynamic stenosis. So it is advised that the patient is placed on a cervical collar. It can be a soft collar or a Philadelphia collar. Upright lateral X-rays of the spine is done to assess the alignment. Patients who require prophylactic thromboembolic devices as before to prevent pulmonary deep venous thrombosis, and physiotherapy should be started immediately. The likely complications that may arise following cervical laminectomy or injury to the spinal cord itself or the nerve roots, and the commonest nerve that is injured during cervical laminectomy is C5. There is risk of infection. There is a risk also for of infection. Injury to the vertebral artery can occur, particularly the cervical C2, if the dissection is done as far as the C2 cervical spine. There is risk of spinal cord leakage, CSF leaks, or pseudo meningocele. This can occur if care is not taken when the kerosene is being used to remove the bone or the ligamentum flavum. Surgery, because of the dissection of the bone, patients are usually at risk of chronic neck pain. So it's advised that minimally invasive access multi-level laminectomy for patients with extensive cervical stenosis will benefit, or even a laminectomy will help to reduce the risk of chronic neck pain. The commonest complication that is seen for patients post laminectomy is the swan neck deformity. The rate can be as high as 23 to 42%. Prognosis or outcome of laminectomy is dependent on pathology itself. Because of cervical stenosis that the patient needs laminectomy for. For patients that have spondylotic changes already, it's been shown that they have about 70 to 85% of cases do well in the sense that the symptoms are usually better, they improve clinically. There is a risk also of acute deterioration following laminectomy, even if they improve. Delayed neurological deterioration can occur 10 years or more afterwards. The total pain relief occurs in about 96% of patients. For
Thank you so much for the presentation, the two presenters. They've taken us through this presentation this evening, from the basic anatomy to the surgical nuances, indications, complications. So it is now time for questions and comments from the listeners. You can indicate by the raise of hand for surgery. Thank you for the questions. Thank you. You may also place your question on the chat so I can read them out for the presenters. Any raise of hand? I cannot see any hand. Is there any? Or you can indicate by voice. You can unmute yourself and ask a question, please, because I cannot see any hand here.
Hello, sir. Hello. Good evening, sir.
Yes, go ahead with your question.
Yes, sir. I'm Dr. Olamiri. I'm from Jos University Teaching Hospital.
Okay. Olalere
Abidemi from Jude. I have some comments, or a comment and some questions. Yeah, I think the second presenter should have made the presentation more spicy if some diagrams, actually maybe intra-operative or some schematic diagrams were added to the slide. And she made mention of some vital information which I would like her to throw more light on. She said that for the physestomy to be unstable, that we should not remove more. We should not do more than 40% fascectomy. How do we intraoperatively measure the 40% of the fitted joint that that should be removed? Then we at what point of laminectomy will fixation be required? At what point do we have to fix the bone, the spine when laminectomy is done? Then the third question is that she said the surgery only corrects static stenosis and not dynamic stenosis. I would like to know the difference between a static and a dynamic stenosis in this patient. And that leads to the fourth question, that for how long will patient be on neck collar post cervical spine laminectomy? Thank you.
Thank you so much for your question. We'll take more questions if there are before we proceed to the answers.
I think there is a question on the chat box, Dr. Samaila.
Yes, there's a question here that says, what is white coat syndrome? How can it be prevented? White spinal cord, white coat syndrome, white coat syndrome, and how can it be prevented? Any more questions? Any comments from the listeners? Okay, if there are none, then we proceed to the questions asked so far.
Yeah.
The first question is from Dr. Olarilere from Jute, and it seems to be directed to the second presenter. So the second presenter, you have the
Yes,
stage.
sir. Yes, sir. Thank you for the contributions as well as the comments. For the first question was, how do we know how much of the facet we will remove? Because I said 40%. In some books, they say 6 to 7 millimeters of it can be removed that is safe for the facets. You can remove 6 to 7 millimeters of the facet, which is safe. At what point should we fix? I feel the indication for fixation would have been determined before even opting for surgery. Remember, I said we'll do the dynamic X-ray before. It's part of the investigation we do before laminectomy. If there are signs that the cervical spine is unstable, then you decide for lateral mass fixation. For the dynamic stenosis, as the word goes, dynamic, I said initially the surgery only offers correction of the static stenosis that we see while the patient does an MRI or an X-ray. So it will be obvious because that kind of imaging is static. When we say dynamic stenosis, we mean the stenosis that will occur while the patient moves in the sense that if he flexes the neck, maybe there is buckling of the ligamentum flavum, that will cause another compression to the cervical spine, although that is already removed when you do your laminectomy. Maybe my professors will throw more light on that. Then the other one is how long do we place the patient on a collar before we remove? For us here, we normally after laminectomy, we advise our patients to have the collars for 3 to 6 months. If there are other contraindications to this, I don't know. Maybe I'll need to do more research on that. What is quiet cord syndrome? I'll need to look on. I don't know what that is, sir. Quiet cord syndrome and how can it be prevented? I don't know anything about that, sir. Thank you, sir. Quiet white cord syndrome. Thank you, sir.
Thank you so much. The person that asked the question on white coat syndrome, do you have an idea to share with the house?
Yeah, good evening. Yeah, good evening, Dr. Samaila. I'm Adeboye from University of Lawrence Teaching Hospital.
You're welcome, sir.
Yeah, it's white coat syndrome is one of the things that can occur following a decompressive surgery at the cervical spine. And then when you finish surgery, a patient may have deterioration of neurologic function, and cervical spine MRI may show upper intensity on T2 and on flare, and that's why it's called white cord. It's as a result of a sudden decompression of the cervical spinal cord with reperfusion injury. So, because of the way the cord appears, the cord substance on MRI, that's why it's called white cord syndrome. So, it's coming from sudden decompression of the cervical cord and reperfusion injury. So what people have said is that well, there's nothing to really do to limit that, but if you can limit your cervical laminectomy, somebody asked about how much level, maybe subsequent contributors can still make comment on that. Somebody asked question that at what level do we do stabilization? So it's still linked to this white coat syndrome. You want to limit the level of how many level of the cervical spinal cord decompression you do. That can limit that occurrence or incidence of white coat syndrome. But generally, it's not something you want to treat, but you can try steroid post-op. Some people have said trial of steroid post-op can help, and physiotherapy, but generally there is no specific treatment for it. But you can prevent it by limiting, but again, limiting the level of, how many level you do depends on the indication ab initio. So there may not be much you want to do about that, but limiting the number of level of decompression. And if it does occur, you have found that every patient deteriorate post-op, you have done imaging, no hematoma collection, and you have not really enjoyed the cord structurally, and you see hyperintensity on T2 or flare, you can try steroid and then physiotherapy may help. Thank you very much.
Okay. Thank you so much for this great contribution to this discussion. Yes, the white coat syndrome, in addition, is a diagnosis of exclusion. So the residents must know that it's a diagnosis of exclusion because cervical laminectomy, beside other indications, is commonly done for cervical spondylotic myelopathy. Therefore, in the MRI of this patient, you may have an established T2 high signal intensity already in the MRI before you even undergo the surgery. However, the appearance of new onset intense signal. Can we help mute our speakers, please?
Yes, I've done that. Go on, please.
Or microphones. Okay, so if there's appearance, therefore, of a new onset hyperintensity on T2 associated with worsened neurological deficit, which sometimes is transient in a patient that has undergone cervical decompression, even thoracic decompression, it is referred to as white coat syndrome. It occurs more in the thoracic region than in the cervical region. And as you know, let me extend a bit to the thoracic region. Posterior approach, is almost an absolute contraindication for decompression of thoracic compressive diseases. That is why we employ the use of posterolateral, lateral approaches, anterior approaches to the thoracic cord because of the large number of complications that may arise, including this white coat syndrome in the thoracic region. It also occurs in the cervical region, but more frequently in the thoracic. In the cervical region, therefore, and even the thoracic, it is said that it is as a result of reperfusion injury most times. And that is because once you decompress an area, there is increased blood flow to that area, which tends to disrupt the normal blood spinal cord barrier therefore exposing the cord to direct influence of free radicals leading to these injuries. And if you've seen one or two persons that has this complication from thoracic spinal surgery, you really understand that it occurs. So the effect, the treatment is as said by the contributor, Dr. Adeboye. So thank you so much. And welcome once more to this webinar. We shall proceed to comments and contributions by our faculty for today's webinar. I am delighted, therefore, to reach the brief session of our faculty for today, Professor Nasir Jinjiri Ismail. Professor Nasir Jinjiri Ismail, who is fondly known as Professor Jinjiri, was born over 5 decades ago in Jahun, Jigawa State. He attended Jahun Central Primary School and Science Secondary School, Dawaki. He proceeded to Bayer University, Kano, and then to University of Ilorin, where he graduated with MBBS in 1991. He subsequently completed internship at the Mursalam Mohammed Specialist Hospital, Kano, and observed the mandatory 1-year NYSC in Nasarawa Specialist Hospital, Kano. He is a fellow of West African College of Surgeons, 2004, and he has other fellowships from International Neurological Institute, Hanover, Germany, lastly, Excel Gamma Knife Fellowship from the University of Virginia, USA, among others. He is a professor of neurosurgery at the Regional Neurosurgical Center, or the Regional Center for Neurosurgery, Usman Danfodio University Teaching Hospital, Sokoto. He is the pioneer head of surgery in the Regional Center. He is the acting provost, College of Health Sciences, Federal University, Birnin Kebbi, and he is a visiting consultant to several hospitals, including the prestigious National Hospital, Abuja. He is an examiner with the West African College of Surgeons, and he has won several awards. He is involved in a lot of philanthropic and community service provision. He is an erudite fellow, an astute teacher, a skilled surgeon, and a meritorious mentor who has trained and supervised over 20 neurosurgeons, some of whom are professors and associate professors of neurosurgery today. He is married and is blessed with children. He enjoys reading and teaching as his hobbies. Ladies and gentlemen, colleagues and senior colleagues, permit me now to welcome on stage Professor Nasir Jinjiri, our faculty for this webinar.
No, that's too much. That's too much. Just say that is Dr. Nasir. Hello.
Thank you so much, sir. With your permission, I welcome Dr. Nasir to stage.
Yes, they're very pleased. The next time, just mention Dr. Nasir.
Thank you,
yes.
Prof.
It's a very good presentation and excellent. I'm happy with the anatomy, and I'm happy with all the approaches, the caution, and the guidelines. My little addition is laminectomy in children. Usually in children, we try as much as possible. We do, we call it open book. We just raise the whole lamina, and when you finish, you put back the lamina and then you cure it so that it is not going to affect the growth for the children. But by and large, most of the indications, the approaches, yeah, it's excellent. I only need to emphasize that the laminectomy one has to be with a lot of caution. As much as possible, if you can preserve seed, even if it is partial laminectomy, and preserving those muscular attachments will go a long way in preventing post-operative swan-neck deformity and other complications. Thank you very much.
Thank you so much, Prof, for your contribution. As I said, it's an erudite professor, and a word from him is like 10,000 words. We are blessed to have this contribution coming our way. We should stick to it. As he said, we should be careful with distorting the anatomy of the spine to prevent the complications that may arise from the loss of the posterior tension band, the loss of the spinous and interspinous, supraspinous, interspinous ligament, the ligamentum nuchae, the erector spinae muscles attachment, and the rest that may lead to progressive kyphosis and swan neck deformity in patients that have undergone surgery, laminectomy, full. Without much waste of time, we'll give this opportunity to our senior participants present, including international participants, consultants, and the rest who are present here to contribute to this presentation and to guide us further. Thank you so much. So you can just unmute yourself and speak to the mic, and we'll listen. Thank you so much.
Hello, Dr. Timothy.
Hi, sir.
This is Dr. Okunodoro speaking.
Chief, you're welcome to the presentation this evening.
Yes, I want to commend all of you, the presenters, the organizers, for this wonderful presentation, as well as the faculty. Nice to hear the voice of my professor, my mentor, Dr. Ginjiri again. This topic is quite relevant. In fact, I'm just coming out from one cervical decompression surgery. It's something that we routinely do. The challenge is that in cervical decompression surgery, you know, it's a surgery that when you are doing, you need to be very careful, because sometimes when you are done, it's not the surgery that you have done that judges you, it's the outcome of the surgery. And we should understand that the cord is auto-regulated, just like the brain. The spinal cord is auto-regulated. So it's prone to hyperemia and ischemia following the fluctuations in blood pressure. So when you are doing surgery, remember the role of anesthesia. The role of anesthesia is very cardinal. Blood pressure should not drop below a certain limit, and you should not have undue hypertension during surgery. If you have all this, and you make sure that oxygenation is well controlled and control the degree of flexion or extension that you do, essentially we try to flex the neck. If you try to over flex, sometimes you may put the spinal cord under serious stretch for some time, and that may cause some challenge for you. That's why that issue of white cord is actually a diagnosis of exclusion, because sometimes it's what happens in trial that causes that injury to the cord, not really reperfusion. Not really reperfusion. If you're able to get good anesthetics that can maintain normal pressure for you, make sure that the cord is well oxygenated, well perfused, not over-perfused or under-perfused, you're unlikely to have some of these challenges in following a spine cervical cord surgery. The role of osteoplastic laminectomy or laminoplasty has been talked about. That is one that Dr. Ginjiri talked about, especially when you are doing spinal cord tumors in children, spinal cord tumors. And most often, we try to do laminectomy that involves removing both the lamina and the spinal processes together as a composite figure. What I would call an osteoplastic laminoplasty. So you go along the sections that you want. Essentially, sometimes you see you have to be along maybe like 3, 4, 5 segments. You remove the whole thing as a block. And when you are done with your surgery, with your tumor surgery or whatever, you bring them back and reconstruct them. We've done that a number of times. It's quite amazing in children, even young people, young adults. We try to do them in some adults, just to help prevent postoperative swan neck deformity. And what I will tell you is that from the revision of the cases we've gone to revise, following some of these procedures, the osteoplastic laminoplasty, we realize that what keeps that composite figure you've removed and replaced back is the reattachment of the paravertebral muscles. The paraspinal muscles try to reattach to them. When you go back to revise the surgery, it's called a reattachment. And without reattachment, they get blood supply and they're able to heal beautifully well. That is my contribution to this presentation. I appreciate all of you. Thank you.
Thank you so much, Chief. We are so glad that you attended and you contributed, and your contributions are well taken, and they will go a long way in reshaping our practice, especially towards our approach to laminectomy in children, as earlier guided by Professor Nasri Jinjiri. Thank you so much for coming. Any other senior? Adegoega, Okwali, Ke, Ghana. Just unmute and speak to us. Thank you so much for coming.
Yeah, thank you very much, Dr. Samaila. Our Professor Jinjiri, we so much appreciate you and all other faculties. I want us to trash this question that was asked by Dr. Olalere. At what point do you consider to stabilize the cervical spine after laminectomy, even though ab initio you have done your dynamic cervical spine X-ray, no instability, the cervical spine was not straightened, no kyphosis, and no kyphotic deformity, but everything was fine. But after your laminectomy, at what point do you consider adding stabilization to the surgery that you have done following the compression, especially if you have taken part of the facet joints? I know some people talk about when you do more than 2 levels for the cervical spine, and then thoracic if you do more than 3 levels. So I want our seniors in the house, Dr. Samaila, Dr. Guga, Dr. Jolayemi, Dr. Ghana, to guide the young neurosurgeons about this particular contentious topic. Thank you very much.
Thank you so much for bringing this back for clarification. I will still want to give opportunity to the names mentioned if there's anybody that will contribute to this question. Jolaimi, Dr. Ganaguga. You can just unmute yourself.
Yeah, good evening, House. If I'm audible.
Yeah, you are clear.
Okay, thank you to the presenters and our faculty for today and the moderator of the House. It looks like a pretty straightforward topic, but as we all know, neurosurgery can always become more technical than you imagine, even when you're going in for something as simple, in quotes, as a cervical laminectomy. For the question asked, there's no hard and fast rule really in most texts that one has come across about posterior stabilization following cervical laminectomies. The concern, of course, would be generally about 3 levels and above. If there was no, that's considering there was no indication ab initio for considering a stabilization. So a patient who, for instance, has an OPLL or just some cervical spondylotic myelopathy extending 3 levels or more, who already has some straightening of the neck. If you are going to do 3 levels and above laminectomies, one would now become concerned about leaving a patient who has that deficit. I mean, that's a loss of normal lordosis with his swan neck. So 3 levels and above, one would consider doing a posterior cervical stabilization, usually in the form of lateral mass screws fixation. But before, these are the patients that should also be considered for the laminoplasties that were mentioned in this presentation, even though not emphasized enough, in my opinion. The different kinds of laminoplasties, door, window laminoplasty, that's also an option for stabilizing. In the absence of that, lateral mass screws fixation would be an option. Thank you.
Thank you so much, Ghana, for this scientific contribution. Do we have any other person interested in adding his voice to this? Just unmute.
Okay, thank you very much. Good afternoon, our faculty, Professor, the moderator, and the presenters. Although I joined a bit late, but from previous compliments, it appears to be a good presentation. Just to add, laminectomy itself, we shouldn't forget, it can be like an isolated procedure that you just go primarily for laminectomy, or it can be a component of a more extensive procedure. Maybe you want to do lateral mass screw with the compression. So that's also is important. So what that means, as was said by a previous somebody that tried attempting the question earlier on, is that one should have a clear objective before you go into surgery. It's not at surgery you start deciding whether you want to instrument, that's to fuse or not. As the number of levels of laminectomy that requires lateral mass screw fixation that has been said, different people have different school of thought, and each of them tend to have similar outcomes. Really, the outcome is what we look at. But I'm not sure there's any hard and fast rule as to the number of levels, but something one should consider is looking at the images pre-op. Now, if a patient has a kyphotic deformity pre-op, you don't just go to the back and take out the posterior tension band and then say you've done a laminectomy without fusing. So that's one major issue, one major contraindication to doing isolated cervical laminectomy. Because if you just take out the lamina and close off the patient is going to come back down the line with worsening kyphosis, and as at that point, surgery is going to be more difficult, with even attendant risks of injury to the dura, to the spinal cord, and to the nerve roots. So in such kind of patients, it's best to address it at ab initio. The patient has a kyphotic deformity with compression. If you want to do a laminectomy, if you don't want to go from the front, then you must stabilize the patient. So I think that's the only one that hasn't been mentioned. And definitely in patients that have 3-column injury, sometimes you look at the spinal cord, the spine also in columns. If you have 3-column injury, for example, someone that has a traumatic C-spine injury, you won't just do a laminectomy and leave the patient. You have to stabilize that level where you think there is some form of instability. I'm not sure of the role of flexure extension studies in the cervical spine, especially in scenarios where you are worried about stability. I think somebody mentioned something about that, but that can be decided upon. And sometimes at surgery, you would, in some very rare cases actually, you find out that the facets are actually weak, and you know that this patient likely would need the lateral mass screw fusion anytime soon. Those kind of patients are probably the ones you keep on a cervical collar for long duration because you're not sure of the stability of the spine. In my own center where I've trained, usually once you do a laminectomy, you don't routinely keep the patient in a collar for that long. In most times, you don't even put the patient in a collar. Do the laminectomy and leave the patient alone. If you think the patient needed the collar, then probably that patient was unstable. Because if you are going to do a laminectomy and you didn't touch the facet joints, it's just the lamina you took, then it's expected that you didn't compromise stability. So really your collar is not doing anything. Rather, it's even weakening the cervical spine models. That's a school of thought though. Thank you very much.
Thank you so much for this contribution. Yes, the issue of collar, you don't need to put collar for too long now. Collar after laminectomy is just to be there until pain is controlled, just short-term immobilization for pain. I don't think it's for stabilization, because if it's for stabilization, for how long are you going to keep the collar? Then in that case, the patient will have had instrumentation in the first place. Thank you so much, sir, for this great contribution. I think we have 2 more persons that want to talk, or we should proceed. Okay, so thank you so much for listening, and thank you for your presence. It has been laminectomy, and we've had a lot from the presenters and those who contributed. There are so many indications for laminectomy, has already spoken. Laminectomy is better typified in the management of cervical spondylotic myelopathy. So if you go through the management of cervical spondylotic myelopathy, you are going to get adequate detail, of the nuances of laminectomy, indication, contraindications, and the rest. Beside the fact that laminectomy can be used as an adjunct to other surgeries or has an access also for other surgeries involving spinal cord. As a primary surgery for spinal cervical spondylotic myelopathy, you have to know clearly the indication. It is said that never has there been any where there is a certainty of decision making and clarity of choice of surgery, than the cervical laminectomy, especially despite the fact that there has been studies upon studies on the biomechanics of the cervical spine, stability and instability and the rest. So if this patient from the beginning has multi-level anterior cervical compressive disease, of course, the choice is to go posterior. Posterior, whether you are going to go laminoplasty or laminectomy, the choice depends on the surgeon. Now, when the anterior condition is more than 3 levels, of course, some people say 2 levels, but you can do anterior cervical discectomy or decompression up to 3 levels successfully and safely. While the approach is anterior, it helps in restoration of lordosis, because we know that in the pathogenesis of anterior disc disease, we know that the anterior aspect of the cervical disc is the one that gives way, first of all, leading to progressive collapse of the anterior column with subsequent compression of the cervical body, leading towards reversal of lordosis and subsequently towards kyphosis if there's associated facetal distortion and instability. So 2 levels anterior, 3 levels anterior, yes, you can go anteriorly, decompress, and put your implants fixed with plate or without plate, but ensure that there's restoration of cervical lordosis. More than this, in terms of disc disease, you have to consider going posteriorly. Then, if there is limitation to anterior access as seen in anterior or posterior florid osteophytes with kissing or bridging osteophytes and or without ossified posterior longitudinal ligament, you know that anterior access is already what precluded, you have to go posterior. Now we have to also know that the buckling of the ligamentum flavum or the ligamentar flava, if it is within the level of anterior cervical discectomy and fixation, by the time you implant the PIC cages or the cervical disc, if you are doing a disc arthroplasty anteriorly is inserted, it tends to increase the height and then the buckling will work correct itself. However, in the presence of multi-level ligamentum hypertrophy and buckling, which may not be what corrected anteriorly, the choice of the surgery is posterior, and when that is done, it decompresses the spinal cord. Now, once a patient has established kyphosis and or without established anterior preclusion or contraindication to anterior approach, you may still have to consider to go anteriorly to decompress if there's no contraindication to anterior approach. So kyphosis alone is not an indication for posterior approach if you can approach this person anteriorly. However, if there is straightening in the beginning, you can choose to do laminectomy, you can choose to do laminectomy with or without fusion. If there is effective kyphosis from the beginning, you can also choose to do anterior decompression with a graft or instrumentation, or you choose to do laminectomy if the levels are more than 3. So I think this is some of the algorithms. So by and large, we've had discussion on laminectomy today, and we can go back and build on what we've had based on the contributions made by our professors, our senior colleagues. in this meeting. Thank you so much. In the absence of any other comments, I wish to thank you for coming, and I will therefore hand you over to the YNNF ESCO. Thank you.
Thank you very much for this beautiful and courage of this program this evening, Dr. Samaila. You have always been there for the Young Nigerian Neurosurgeon Surgeon Forum. I want to thank Professor Nasir Jinjiri and all our senior faculties who have made this session something we could part 1 hour with for this evening. Dr. Palike, the East Coordinator of YNNF, and the presenters from University of Benin Teaching Hospital. You have represented your center very well. Thank everyone for making it this evening to this program to further help us both in our academics and also in our practice. As one of our faculties has spoken, we just finished another decompressive laminectomy this evening. So it's a common thing that all of us, we have to have something to do at one point or the other in our practice. So thank you very much for this evening participation and the contribution. Next month, last Friday, I think that should be 26th of July, we'll be having another wonderful, robust discussion still on neurosurgery. Thank you very much. Have a beautiful evening. Dr. Kuga sent his greetings. The chairman of YNNF is unavoidably absent this evening due to a surgical procedure. So thank you, everybody. Have a wonderful weekend.
Thank you, Chief for coordinating. Thank you, everyone. Thank you, presenters. And thank you, Chief of Quality, for being there for us. See you next time. If you have any question and discuss with your faculties, you can also call us individually and we can clarify for you. The aim is to make us better in our practice and to also help us in our academics. So the resident take it very serious, reverse it, and it's going to be of help to you now and ever, as long as you remain in your surgical practice. Thank you.
Bye. Thank you very much, everybody.
Bye. Thank you.